Hello farmers, I hope you're all doing great. Today I want to talk about how to jump into a new topic when preparing for the NAPLEX. Specifically, today is about GERD. So I'm hoping this will be a weekly series, but for now we'll keep it bi-monthly. So to start off, you want to know where this information is coming from. If you're opening a chapter in your RX prep book, you should go straight to the sources. Find out where this is coming from. It's likely up to date depending on your book. For GERD, we have the same guidelines we've had for approaching 10 years. So these are the 2013 guidelines for the diagnosis and management of gastrointestinal reflux disease, which is where I'm pulling all of my information from for this video. According to your NAPLEX bulletin for every year, it is possible to have questions related to guidelines because they want to know if you know where your information is coming from. So at this point, there's no perfect direction as to where to start when you approach a new chapter or a new subject for the NAPLEX. I personally think of my biggest questions. If I want to know what drugs are used to treat this disease, then I immediately would start looking into the chapter via the drug section. Sort of answer my questions and remind myself of these things I've already learned previously. With GERD, you will see it a lot in retail pharmacy and even in your own life, family and friends. It's also known as heartburn. So the muscle tone is weakened, and that sort of causes a backflow to come up, and people recognize this pretty immediately and associate with heartburn. The problem comes because they don't know which medications they should choose. There's lots of brand names out there for antacids and your proton pump inhibitors, even the H2RAs. So a great place to start would be determining that they have heartburn and evaluate them for any of the sort of symptoms that means, oh, you should go to the hospital. We don't want to treat outside of our scope of practice, and this is especially true on the NAPLEX. So when you're evaluating patients, you want to look for when the answer is going to be, there's nothing I can do, you need to go to the hospital. I can't help you here. Of course, in real life, you do want to inform them and tell them what you know, but on the test, it'd likely be, hey, you need to go to the hospital. You need to talk to your primary care doctor. So we start by confirming that the patient is experiencing these symptoms of heartburn, the reflux pretty much, at least twice a week. And that tells us that they should start using the OTC products. Now, if they are already on the OTC products, which is pretty common, and they've been doing that for over 2 weeks and no relief from any of them, the antacids or the PPIs, they should, well, that's out of your scope of practice, so you should refer them to their primary care doctor. The alarm symptoms that are cause for referral in the guidelines, we have anyone using the OTCs for over 2 weeks, as I mentioned. We have blood. So if they're coughing up blood or if they have bloody stools, they need to be referred. If they're having unintentional weight loss, that's cause for a referral. Frequent nausea and vomiting. And this big one, which you can easily miss, in my opinion, when you're reading a patient case, difficult or painful swallowing. If the patient says they have this, that's out of our scope and they need to go see their primary care physician. The occasional GERD likely can be treated with your OTC products, and it is something that pharmacists are great for, especially educating. The idea is that something is causing it, but we can fix the symptoms, and as long as they don't have that reoccurring after that 2 weeks, they don't necessarily need to go see their doctor. Now, if they did see their doctor, they would be put on a 8-week course of your PPIs. This is first practice now just to stop any possible ulcers that have formed. Since that's a treatment for ulcers and it's going to help with their GERD, the 8-week course is the way to go. Unlikely to see anything after that as the ulcer would have healed. So after 8 weeks of a PPI, patients should stop their PPI and switch to a maintenance therapy, which would include an antacid or an H2RA. The reasoning for not being on a PPI forever, which a lot of people are, you'll see it all the time. It's something that's always auto-refilled. Using PPIs indefinitely can, well, of course, lead to infections, but it also can lead to bone disorders, osteoporosis, increased risk of fractures, especially, in elderly people. Now, in the guidelines, the percent is low. But as far as the NAPLEX goes, you need to know that patients should generally avoid taking PPIs over that 8-week course, and they should start the next course of therapy, which would be maintenance, and get on an antacid or an H2RA. So reading into the guidelines more, your maintenance therapy first line is actually a PPI at the lowest dose. So it is sort of recognized that the risk of reducing the long-term acid suppression is low, but we know that it can cause infections. We know that it can cause osteoporosis. This concept is actually important for elderly patients, so we do want to make sure that they don't continue the use of the PPI indefinitely. So you will have patients who you find on that, and you can make that recommendation. You also want to avoid your H2RAs. They cause general CNS defects, and we don't want that for our elderly patients. So for anyone that's seems old, you pretty much want to start them on an antacid and help them through it. So let's start by going over the proton pump inhibitors, since those are first line for when someone is diagnosed with GERD and is first line for maintenance therapy. You pretty much know it's going to work, and that's kind of the important part. So I immediately think of omeprazole. I think of omeprazole. I think of pantoprazole. So pantoprazole is Protonix. Omeprazole is your Prilosec. There's lansoprazole, which is your Prevacid. There's esomeprazole, as I mentioned, which is Nexium. And there's also Dexilant, which is a brand for dexlansoprazole. Dexlansoprazole. So these all would have the warning of infection when used frequently. So C. diff is a big thing we're looking for in terms of, you might get asked on a test, these drugs cause C. diff. Yeah, your PPIs can cause C. diff. And then there's the fractures in your elderly. In my opinion, those are the big ones. There are some other ones you can sort of look into and get a big idea of. Headache and nausea. Those are common with PPIs as well. Something interesting about the PPIs is that they are taken daily, and for maintenance you want to use them at the lowest effective dose, but you will see prescribers, because they've done it before and it works, giving these out to be taken twice a day, even though they should work throughout the day. But that's something that's pretty common, but that's not the recommended dosing. The dosing recommended is typically daily and at the lowest amount that treats the patient. Although a big reason to do the twice a day would be as if there are symptoms that come up through the night. If a patient has nocturnal symptoms, it would be helpful if they took their omeprazole around 5 p.m. before their meal, and that should reduce those symptoms at night. But that's also why it's important to talk with them about their triggers. Before we move on from your proton pump inhibitors, you should know that they do irreversibly bind to their target in the GI, the HK-ATPase pump. It is an 8-week course, and of course maintenance therapy at your lowest dose. So the PPIs, they block the gastric acid secretion, and then you have your H2RAs, which does reversibly inhibit the H2 receptors, which decreases your gastric acid secretion. Now, some of these are over-the-counter and some of these are prescription. Your over-the-counter, there is Pepcid, you see that a lot, famotidine. There's Zantac, which is ranitidine, which is an important one to remember because it did have to leave market after the FDA found that ranitidine could sort of build up cancer-causing cancerogens over time. So they did remove ranitidine from the market, including Zantac. Side effect wise for H2RAs, there's that CNS depression. So you don't want to use these with elderly people when it comes to maintenance. So you don't want to use PPIs either. So that only leaves antacids for your elderly. Unless they are being treated for their GERD, that's the only way they should be taking an 8-week course of proton pump inhibitors. Other than that, an elderly person should be on an antacid. With HRAs, you do also need to lower the dose for renal impairment, which could mean if someone's renally impaired, you might want to pick something like an antacid or a proton pump inhibitor. The last of the drugs on the list is your antacids. So antacids just neutralize that gastric pH that's already there, and they can help pretty immediately. So antacids are great, and people take them pretty regularly. Some examples would be Tums. You see that a lot. That's calcium carbonate. You'll also hear people talk about Alka-Seltzer. You'll hear people talk about your milk of magnesia, and these are antacids. With your calcium, they do cause constipation, and your magnesium can cause loose stools. So, in my opinion, that's a great question. Who knows if you'd see it, but in terms of antacids, the calcium containing can cause constipation, and your magnesium can cause loose stools, can really help you determine which one to use for an elderly patient who needs maintenance therapy. So all these medications are common because people have heartburn, which means we know of lots of drug interactions with this medication. The best way to know them, in my opinion, is learn them as you go through the other topics and the other drugs, which is kind of why I wanted to start with GERD, since you will see it a lot in real life, and knowing how to treat it all the time is going to help. So your PPIs, of course, are your first line, but there are alternatives in the sense of non-pharm, so your lifestyle modifications. The immediate one is going to be weight loss, and it's going to be avoid those trigger foods. So being able to sit down with someone and determining what's causing their GERD can really help. It can help more than medication can, because a lot of people don't want to take medication or they forget. For PPIs and your HRAs, you typically take them before a meal, and that can be hard. Big one is to avoid those high fat foods before bedtime. And then there's the sort of the lazy boy where you elevate your head when you're sleeping to reduce those symptoms. Lots of things to think about with the GERD. Let me know if you like this video. Definitely like, subscribe, guys, help it grow. And I will try to do another one as soon as I can.